first one, it was an office record. And I found it interesting. When I started going through this, I thought, I want to make sure that you understand as a student, but as an employee, a coder, that this is an actual record and that you need to be able to define what these abbreviations mean. So I actually took time to write that in to this report. So we're going to look at this report in a little bit more detail. But we've got our chief complaint here, and it's sore throat, cough, sneezing, headaches. These are all symptoms. This is a 48-year-old male that's come into the office. He is an established patient, which we need to know if it's an established or new before we work on an E&M code. We see that the patient has hypertension. We see that his past medical, family, social history is not available. So if you're in the office, you would have access to that, but not here with this particular form. The review of systems is to see the history and physical. When we got down to the physical exam and the physician documented everything, we can find right here this FEN. Okay, that is a typo. And I wanted you to know this is an actual report. So these are things that you've got to be aware of when you're coding for a physician's office, because this FEN should be GEN for general. Okay, this is a male, pleasant, and the vital signs are reviewed, within normal limits, no abnormalities. So we want to pay attention to our abbreviations. Then we have the next line. We have just a line full of letters. Let's talk about, this is the cardiovascular. We know that he's in the cardiovascular. We know that the patient's not tachycardia because he says not tachy on the exam. But then I want you to know, and then the RRR, we probably know what that is, regular rate and rhythm. But what is MRG? Is this actually murmurs, rubs, or gallops? And see the dash that the transcriptionist put in front of that? That means negative, non-existent. Okay. Then we go down here and we've got our next line, which is our HEENT. And I put this in parentheses so we can look at each one of these and you can see what they are. Head, eyes, ears, nose, and throat. Pupil, equal, round, reactive to light and accommodation. Then this next EEOMI. Ears, eyes, nose, and throat, extraocular muscles intact. Then this CC is clubbing cyanosis, and then no icterus. And icterus is an indication that's jaundice, yellowing of the skin, which can be caused from your pancreas, gallbladder, or liver malfunctioning. The next is MAL. Posterior cobblestoning erythema. All right, so next, shoddy LAD submandibular. Let's look at this. Cobblestoning is actually irritated. Your throat's irritated. And in the back, when the physician does the throat exam, there's actually bumps and lumps at the back of our throat. Then when he talks about the LAD submandibular, the LAD refers to enlarged lymph nodes, which are located beneath the lower jaw. All right. The extremities, no edema, psych, negative, not indicated of any mood or affect or memory disorder. Skin, warm, dry, and intact. Now, everything that we've just reviewed is within normal limits. If it had not been, then we could have potentially picked up additional diagnoses by reading through this and understanding what these abbreviations mean. So that's why it's important that you don't just read the chart. Of course, there was nothing to code in this one, but there could have easily have been, and there may be on the next one. So you want to look at an abbreviation list. I know we had one in the course, but I Google, and there's hundreds of abbreviation lists that have these abbreviations on the internet, and that would help you. So I want to take a little bit of time and go over what they meant and why they are important, because they could indicate a diagnosis. Okay, so the assessment and plan, the physician has determined after his examination that the patient has acute bronchitis. So that's one diagnosis. Now, his plan for that is fluids, rest, ibuprofen, or Tylenol. And then he ordered a prescription of azithromycin, which is an antibiotic, and then instructed to call with worsening or changes. The second diagnosis that he indicated in the assessment was the hypertension. And it's stable, mildly elevated pulse today, but there's no indication that that's a problem. The patient's on Norvase and HCT, but the patient is to avoid decongestants, because decongestants that might treat acute bronchitis are also known to possibly elevate our blood pressure. So the fact that the hypertension it's mentioned here, but it's also affecting the treatment of the patient, because, like I said, it could elevate the person's hypertension, and you're going to take a lot of times the decongestants and other antihistamines over the counter to treat acute bronchitis. So those are our two diagnoses that I picked up, and I believe I don't have Michael's. Michael, you'll have to tell me when we go over this. These are the two diagnoses that we picked up: acute bronchitis and hypertension. I'm going to have to move. I had to move away a little side tab here. So we want to look up bronchitis in our Find a Code. And when we look up bronchitis and we drill down, we find acute J20.9. And we're going to come over here, because one thing that I have tried to emphasize to all the students is, when you get to this code, don't just stop right here. Yes, that's what we need, but you're learning. You're in a learning mode. And I will be very honest, you will always be in a learning mode, because there's always things to learn in the coding world. There's always new diagnoses that you're not familiar with. There's always new procedures. Educate yourself. If you want to be successful and be a very good coder, then it's not just about assigning these numbers. It's about understanding what the diagnosis is. And you have the perfect opportunity here with Find a Code, because you can scroll down and you can read this common language description. It's so important that you take the time to read this and understand what acute bronchitis is. And all this information is available to each one of you. So I want to emphasize that here at the very beginning today. But as we go through this and we see J20.9, you also want to look at each of the notes. You have includes, and then you have an excludes one. We don't have this here, But if we had, we would know that an exclude 1 means it could not be coded. We have excludes 2, excuse me. And then we have notes, and these use additional. Now, what if the patient had a history of tobacco dependence? If that was in the chart and that was documented, even though it was not in our assessment and plan, but it was in the documentation, you would have picked that up and coded it because we have an instructional note telling us to. The one thing, physicians aren't coders. They don't understand the coding rules to the depth of using these type notes. They get coding, but they don't get the entire concept. You are the coder, you are the professional that will help bring them the revenue into their office. So you can bring in the correct revenue or you can bring in the wrong revenue. So it's your job to understand coding, and it's his job to understand how to treat the patient. Okay, so we're pretty comfortable that we don't have any of this in our chart. And our first code is J20.9. Then we see we had hypertension. My guess is you've been coding long enough now, you probably know that one by heart. But we're going to pick it up. And go right here with it. Look at all these options I have. Let me see.
You're not seeing
I
that
have
part of your
hypertension.
screen.
I'm sorry, Michael. What was that?
Okay.
Can you see my screen now?
No.
Okay.
You can change it or expand it so you can see it.
I see what you're saying. You want the
Good,
entire. Okay. Does that help?
Yes,
Okay, we
it's
can.
okay. This can help. Yes.
All right. All right. I can do that. All right.
All
So we have, when we open up for hypertension, we have several options. And so you've got to scroll, you've got to search. And right here, we know that we have just essential hypertension, which is just hypertension. There's no other diagnosis to associate with the hypertension. So I'm going to open this up. And when I open it up, it clearly says it includes high blood pressure, hypertension, and remember these parentheses are non-essential modifiers. Just because it has the word malignant hypertension, it doesn't mean this is a diagnosis of malignant hypertension. This means that if malignant hypertension was stated, this would be the appropriate code. So these are non-essential modifiers. Okay, so we want to continue to scroll down. Once again, we have our use additional codes. And then we have our common language description. All right, so I'm going to change this back and come back over here to our patient. All right, so we have two codes for this patient. Our J20.9 for the acute bronchitis and the I10 for hypertension. Any questions on the diagnosis coding?
No.
I think
No.
you all,
I'm
I
okay.
felt like y'all were
I
comfortable.
understand it. Yes. I'm comfortable with those diagnoses.
Very good. All right. Let's look at the E&M level. This is where we have a little bit of struggle here because we want to assign the higher level. And the physicians want the higher level, but it has to be validated. So we're going to go in All right. And I will, let me get to the page that I'm looking for, and I will certainly bring it up for us to see clearer. All right. When I'm doing this, I always have my little scratch piece of paper, and I forget I'm not on video, so you can't see me. I have a piece of paper and I have my pencil, and I have 3 different columns. I have a problem column, I have a data column, and I have a risk column. So if I'm doing that, then I'm going to go over and I'm going to figure out, first of all, my problem, and I'm assigning the level. This patient had acute bronchitis and hypertension. My hypertension, I'm looking right at it, 1 stable chronic illness. So we know we have hypertension is a low. What about our acute bronchitis? That meets the definition of acute uncomplicated. So I have my book open, and you can certainly do a split screen on your computer and have this on, just like I do, on the right, and your chart on the left, and you would scroll back up to the definitions if you're not sure if acute bronchitis falls in this category or not. But our book tells us, when we look at the definitions, or you don't have a book, so your encoder, when you scroll back up, your definitions, acute uncomplicated illness is a recent or new short-term problem with low risk of morbidity for which treatment is considered. And some of the examples in the guidelines here are cystitis, allergic rhinitis, simple sprain, etc. Our acute bronchitis falls into the low level. And it's an acute, it's uncomplicated. We didn't have any indications of no specific bacteria. He didn't indicate any respiratory complications. So we definitely have a low level problem. Data, we had, okay, Michael, did you have a question?
Yes, I have question, because
Okay.
this place, at first I choose medical decision making law, but when I look into the symptoms again documented, and now I saw the acute bronchitis, the symptoms documented in the chief complaint. So I now went and choose the moderate, where it states one acute illness with systematic symptoms.
Okay, if I chose systemic symptoms, then I've got to
Yes.
have a diagnosis to back that up. Such
Okay.
as systemic's going to affect our body systems, such as kidney failure, respiratory failure. We don't have any indication that the bronchitis has affected any other body symptom, any other body system in our diagnosis. So,
Okay.
but I want to encourage you, because those are really good questions. I want to encourage you to go in and look at your definitions. One of the examples of acute illness with systemic symptoms would be pneumonia. Okay. Colitis, pyelonephritis, kidney dysfunctions. We don't have any body system disorder. Does that help?
Yes, okay.
Okay. Yes, Daniel.
Okay, yes. I think I have the same concern that borders on 99213. when you look at the report, you see that the patient struggle with the OTC, that's over-the-counter drug, and it didn't help at all. So on the return, the physician gave a prescription drug, and it means it's a prescription drug management. So shouldn't that change anything?
Okay. Let's go across, because the first thing you have to do, and I'm going to pull back up. This, because this is the best way that I explain it to myself. So let me try to help each of you here. Here's my columns. Okay. All right. My acute uncomplicated is a low. So I've got low. My data, I didn't have any. I didn't have any x-rays. I didn't have any lab. So that is straightforward. Minimal or none, correct? Now, my risk is exactly what you're thinking. My risk is moderate because I have a prescription. So I have a low level problem. I have a straightforward data, and I have a moderate risk. I have 3 different levels. As a matter of fact, this is not even documented. So I want you to look at this and read and look what I've written here. When each element is at a different level, you must choose your E&M level based on the lowest documented component. We have documentation for this, and we have documentation for this. Our lowest level is 99213. You cannot assign a higher level in this type of example. Question: did we lose Michael? I think so. Maybe he'll come back on. Okay. Does this make sense, Daniel? Because I know that you assigned 99214. And I know why. Because we've got a prescription going on. But we don't have what we need to be able to assign that level for this position. We would have needed 2 out of 3 would have got us there. If we could have made this an acute illness with systemic, wouldn't have been good for the patient, but it would have been good for the level. And we didn't have any data. So, you know, that there's nothing there. This patient actually walked in. He's got acute bronchitis. That's it. He's got hypertension, which is stable. And the physician gave the patient an antibiotic. It's a very simple visit.
Okay.
Okay, Amara.
Yes, I wanted to ask for the chief complaints, is it that we shouldn't code them as ICD whenever we see them? Is it always symptoms?
9 out of 10 times it's symptoms. And
Okay.
if we look back at this particular documentation, our chief complaints, sore throat, cough, sneezing, headaches, and we look at our diagnosis of acute bronchitis, and let's say we're not familiar with what acute bronchitis is, I want you to Google, or you can go over here to your common language description. Whatever works for you is what I want you to do. because those are all symptoms of acute bronchitis.
Oh, okay. Yeah, because I googled it. That was why I was able to code and I got 99213 as my CPG.
Did you get 992? Awesome. Yeah, that's great. All right. Michael, we lost you in your back. Thank you. Any questions? We were going over this kind of table right here. So I'll briefly go over it because I think you missed it. And this is very important. We looked at these 3 columns. You have to take each column individually. If we look at our acute uncomplicated, we fall into the low. And I'm not worried about the code numbers right now. I'm worried about the level. If I look at my data, I have no data. So that's straightforward. There was none. You can see over here. My risk, I had a prescription. The patient was given azithromycin. That puts me under it. But I can't bill if I'm coding this. I cannot code and bill this as a moderate because the rules say when each element is at a different level, you're going to code based on the lowest documented component. And that documented component is what I want you to see. We have no documentation in our data, but we do have documentation in this level and in our risk. So we have a moderate and a low, and we must choose the lower when they're different. And it's based on documented component. I want y'all to really grasp that because a lot of times this column may be empty. And you may have a moderate here and you may have a high here. And that's going to be moderate. It wouldn't matter if the moderate was over here and the low was here. It does not matter which column. What matters is the elements and how they are assigned based on each medical decision making in our table. Questions. This is very important because this is a very when you're working for a physician's office, you will be doing this. And we'll work through some more, not of course today, but in the future. Because after you do it a few times, you get it. To begin with, you're kind of like, you want to go with the higher level, and the rules just do not allow us to do that. Okay.